Μετά από τον καθηγητή Λεωνάρντι που μας είπε όλα αυτά τα ενδιαφέροντα και ερωτήσεις ακριβώς εκεί στόχευαν, επειδή περισσότερο από εμάς είμαστε κλινικοί ή κάνουμε κλινική έρευνα, ήταν ακριβώς σε τι θα μας ωφελήσει όσον αφορά κλινικά όλη αυτή η μελέτη. Σίγουρα καταλαβαίνουμε καλύτερα την φυσιολογία και όλα τα σχετικά, και από τον χώρο της αλλεργίας στην οφθαλμική επιφάνεια πηγαίνουμε σε λοιμώξεις που αφορούν και την επιφάνεια, που κυρίως είναι το θέμα της στρογγυλής τράπεζας, αλλά και συνδυασμό της επιφάνειας και των ενδοφθάλμιου περιβάλλοντος. So, Dr. Agarwal from India is with us. Good afternoon, Dr. Agarwal.
Good afternoon.
Thank you for your contribution to our Congress, combined with iOS Congress in Thessaloniki. And I said after the lecture of Professor Leonardi that the ocular surface is field of research in pathophysiology, in basic medicine, and the biotechnology and laboratory evolution give us the opportunity to have a deeper look in those in the diseases of this structure, I mean the ocular surface. So you can start, and your lecture is viral keratitis and keratouveitis. That's why I said that you have to deal between the ocular surface and the concomitant involvement of ocular surface and intraocular environment.
Thank you so much for having the introduction. I hope you all enjoy my lecture and would be happy to answer questions.
Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to be a part of this wonderful meeting. For the next few minutes, I'll be talking about a very important uveitic condition, viral uveitis. So when we talk about uveitis, the anterior uveitis is the most common form of uveitis. It can be acute, chronic, or recurrent. And symptoms, they're usually, in acute cases, patient presents with sudden, painful decrease in vision, along with photophobia, tearing. But when it's a chronic uveitis, it's usually the blurred vision, or sometimes patients can even be asymptomatic. It is infectious or non-infectious. In adults, we know that anterior uveitis is actually B27 related, which is most common. But in children, the JIA-related uveitis is what we know is more commonly seen. The novel molecular diagnostic tests and serological tests in viral anterior uveitis are very important, and the most common infectious anterior uveitis is viral uveitis. So this is just to reiterate this, a patient with actually B27 related uveitis presenting with unilateral non-granulomatous uveitis with fibrin and hypopia. And how does JIA related uveitis present? It is uveitis in a white eye with no congestion, but we see a band-shaped keratopathy, posterior synecdoche, and then cataract. In chronic uveitis, what we normally see, these mutton fat keratic precipitates, iris nodules, and again, these are large keratic precipitates, posterior synecdoche. Usually, we see these in sarcoidosis, tuberculosis, or patients with Vogt-Koyanagi-Haradas syndrome. And this is just another infectious anterior uveitis, a patient with syphilis, presenting with granulomatous inflammation. RPR and TPHA was positive, and patient usually is treated with penicillin intravenous injections for 2 weeks along with topical steroids. So when we talk about viral anterior uveitis, the clinical features, they're usually unilateral. They have diffuse, fine, medium-sized stellate KPs, iris atrophy, raised intraocular pressure, and complications like cataract and glaucoma. They do have some overlapping features with other anterior uveitis. When we talk about varicella zoster virus or cytomegalovirus, anterior uveitis is commonly seen in immunocompetent patients, whereas posterior uveitis is seen in immunosuppressed patients. It can be associated with keratitis and scleritis. Serological tests are of little value in these uveitic cases because of the increased seroprevalence. But PCR and Goldman-Whitner coefficient, if positive from aqueous sample or vitreous sample, it's definitely diagnostic. So what are the symptoms when we talk about viral uveitis? In patients who have HSV or VZV uveitis, they usually present with acute pain, redness, watering, photophobia, with or without vesicular rashes on the face, and a unilateral headache. But when it is seen by anterior uveitis, Boschner-Schlossman, they have acute onset of halos and blurred vision, unilateral headache, and then again mild redness. But patients, if uveitis syndrome due to Fuchs uveitis, which is more commonly due to CMV or rubella, they have chronic blurred vision with floaters. Let's talk about the clinical signs in these patients. Skin lesions. Patients, if most commonly in HSV and VZV, they present as unilateral skin lesions on the forehead involving the eyelid and also the nose. As we see in this patient, tip of the nose, Hutchinson sign is involved. And these are vesicular eruptions involving the eyelid, the forehead, nose. And this is a patient who had CNS lymphoma and post-immunosuppression. He developed the lesions, herpes zoster, and these are the post-resolution of herpes zoster. And these are again patients with unilateral lesions on the face and the forehead. It involves the cornea, and patients can present with dendrites, pseudodendrites, or geographic ulcer. As we see here, these are bulbous ends, a patient with large geographic ulcer, multiple dendrites on the corneal surface, or a broken dendrite, or what we call as geographic ulcer. But it can also involve the stroma or the endothelium. When it involves stroma, it presents as disciform stromal keratitis. Here we see there are Descemet's folds and keratic precipitates. So it's endothelitis. Another patient with disciform lesions, nummular opacities, and these whitish KPs. If you look carefully through the corneal edema. And here this is a patient with diffuse KPs and cornea is decompensated with bullous changes. Another patient with milder form, nummular scars with keratic precipitates. And here the patient has necrotizing keratitis, but we look carefully, we can see through them the KPs which are on the endothelium. So I'll share an interesting case here. This is an 8-year-old child where we did the corneal scraping and it was HSV1 positive. As we see, this was a necrotizing lesion along with corneal vascularization. 1 week later, post-treatment with oral Valsivir, cyanoacrylate glue and bandage contact lens, oral and topical steroids. This patient is healed completely, leading to a leukomatous opacity at 3 months. How about keratic precipitates? Are they different from other cases in uveitis? Yes. In viral uveitis, what we see is pigmented keratic precipitates, which are diffusely scattered, crossing the midline all over the cornea. This is a common presentation. They can be granulomatous or non-granulomatous. They can be in clusters, as we see in this patient. We see in a cluster in the inferior quadrant. Or they can be all over the cornea, as we see in these patients, herpes simplex uveitis or herpes zoster ophthalmitis. But what about Fuchs uveitis? Fuchs uveitis, the KPs, they are dendritiform, they are diffuse, they are stellate keratic precipitates and very fine filiform keratic precipitates. And we can see there are no synechiae here. Keratic precipitates with KPs, they are usually in the area of inflamed cornea. As we see, there is stromal edema and there are KPs which are really hidden behind the stromal inflammation. I share another interesting case. This was a patient with pain, redness, and decreased vision for 1 week in the right eye, and she had undergone cataract surgery 3 months back. But at this point, visual acuity dropped to 3/60. So what we are seeing is multiple mutton-fat KPs with DM folds. Aqueous PCR showed HSV1 positive, and she was treated with Valsivir tablets and topical steroids. And this is the follow-up at 1 week and at 5 months, complete clearing of the cornea. Another interesting case, patient underwent the 3rd PKP and was on treatment with oral and topical steroids along with azathioprine. But at 6 weeks, she comes with blurred vision. And what we are seeing here, there are KPs which are in ring pattern, clumps, and they're grayish-white. An aqueous tab was done, and what we see was CMV positive. She was treated with tablet ganciclovir and topical ganciclovir along with steroids. So what if it is not cornea? The other thing what we see is anterior chamber inflammation. It can have hypopyon, or it can have hyphema. Most commonly, it is HSV and VZV, which is more severe in VZV infection. Why? Because VZV, it invades the root of the iris epithelium, causing occlusive vasculitis, whereas in HSV, it causes iris pigment epitheliitis. Iris atrophy is another very important clinical sign in these patients. The iris atrophy pattern, it can be sectoral, it can be diffuse, it can be spiral. It can be seen both in HSV and VZV, but also we've started to look into these CMV patients in acute cases as well as chronic cases. Like Fuchs uveitis, what we see, look carefully. Here there's a diffuse iris atrophy involving the whole iris. What is evident here is clearly iris stromal atrophy. And CMV is the most common organism which causes iris stromal atrophy in these eyes. But it's very important that we differentiate this clinical entity from ICE syndrome, which also has these iris atrophy patches. I'll share another interesting case. This was a 48-year-old male who had come to us with decreased vision 3 weeks post-cataract surgery. Visual acuity was 636. Specular was non-recordable, increased corneal thickness. And this was diagnosed to have, probably it's a corneal decompensation or toxic anterior segment syndrome. At 1 month post-treatment with topical steroids, visual acuity improves to 624. The Paki was still 660. What happens at 4 months? We see when he comes for a follow-up, there's diffuse iris atrophy around the pupillary edge. At this point, I did an aqueous tap and this was CMV positive. Patient was treated with oral valganciclovir along with topical steroids and anti-glaucoma medications. And this is at 7 months. Cornea is fairly clear and inflammation is under control. But there's diffuse pigment dispersion on the endothelium. So visual acuity improves to 6.9. The next comes pupil. Pupil normally in these eyes is distorted. There are posterior synegia, which is more commonly seen in HSV and VZV, anterior uveitis. Again, pupil can be distorted. It's because along with iris atrophy patches. But in Fuchs patient, pupil is usually round. Ocular hypertension. IOP is elevated. It is directly proportional to the viral load because the outflow obstruction due to the inflammation of trabecular meshwork. In HSV and VZV, there are episodic bouts. But in CMV, IOP elevation is mostly disproportional to the viral load and it's permanently raised. The viral uveitis can also be associated with adjacent scleritis. As this case, we see that there is corneal involvement, there is fibrinous uveitis, and there is scleral congestion. And this is another patient who had a history of facial nerve palsy. We can see healed corneal lesions, and now patient has scleritis. This is another patient who was diagnosed to have immune-related scleritis unless he presented with a corneal involvement, a disciform corneal lesion. And at this point, patient was diagnosed to have viral sclerokeratitis. So what about posterior uveitis? Acute retinal necrosis caused by HSV1, 2, and VZV. Virus, it's most commonly seen in immunocompetent patients, unilateral most commonly, and presents with a triad vitritis, arthritis, and retinal necrosis. What we are seeing here is peripheral retinal necrosis along with arterial involvement. There's another patient with a colored montage which shows peripheral involvement with viral necrosis, retinal necrosis. And it may not be just peripheral, it can still involve the posterior pole also. There's a young patient who had blurred vision post-fever, and this was the yellowish lesion which is involving the posterior pole, and this is post-treatment with antivirals and oral steroids. Another patient, retinitis post-febrile illness. This is pre-treatment where we see that along the vascular arcade, yellowish retinitis lesion with macular star, and this is post-treatment. And this patient, 36-year-old patient who had blurred vision for 2 weeks with fever a month back. Anterior chamber cell inflammations, which was cell seen. Patient was treated with oral acyclovir and steroids. So if not HSV and VZV, CMV retinitis can also be seen in patients, especially when it is an immunosuppressed state. HIV positive patients, organ transplant patients, or on immunosuppression, when the CD4 counts fall less than 50 cells per microliter. What we see clinically, fluffy white retinal infiltrates along the vessels with retinal hemorrhages. What we all know is pizza pie appearance. And this is a patient, progressive outer retinal necrosis, the cracked mud appearance. Mostly seen in immunosuppressed patients, it's a diffuse retinitis and retinal vessels are spared. So what are the other viral uveitis besides herpes viruses? This is a chikungunya virus, which we all know now, caused by an alpha virus, and it's endemic in Africa, Asia, India, and South and Central America. It can present both as anterior uveitis and posterior uveitis. Here is a patient bilateral posterior pole retinitis, and patient had fever, petechial rashes, and arthralgia 3 weeks back before the ocular symptoms. Dengue virus associated uveitis is another important entity we all must be aware of, where anterior uveitis may present even 5 months post systemic disease. And this is a patient who developed panophthalmitis after 10 days of being diagnosed as dengue fever. Zika virus associated uveitis, it was first reported in Uganda, and it's an RNA flavivirus. Acute infection can cause anterior uveitis with non-purulent conjunctivitis, high intraocular pressure, and panuveitis. Ebola virus also can present as anterior and posterior uveitis, episcleritis, interstitial keratitis, leading to cataract and glaucoma, and it has poor visual prognosis. So when we talk about these viral uveitis, what are the complications that we all know in posterior uveitis? It can cause intense vascular occlusion, thereby leading to macular ischemia and optic disc failure. The investigations, the aqueous, vitreous fluid, and serum, where polymerase chain reaction is the test for these patients, but it can still be false positive because of the latent viral DNA in leukocytes. And false negative can also be seen when it's a low intraocular viral load, limited ocular fluid sample, and it's a short-lived phase of DNA, or when there are inhibitory compounds in the fluid sample. Goldman-Whitmer coefficient, it detects the pathogen-specific intraocular antibody production, but we say PCR is more useful in immunocompromised patients. Viral culture is expensive and time-consuming. Specular microscopy, ASOCT, and confocal microscopy are the tests which we do in CMV-induced endotheliitis. What is the treatment? Antivirals, because it stops viral replication and avoids the complications. We have the options of topical, oral, intravenous, and intravitreal drugs. Steroids, they prevent ocular damage from host immune response. Again, can be given topically, orally, or intravenously. Anterior uveitis, we have steroids, oral, and antivirals. But posterior uveitis, intravenous antiviral drug is the therapy. They're also given anti-glaucoma therapy along with the antiviral treatment. In conclusion, I would say viruses, they are most common cause of infectious uveitis. Diagnosis is mainly clinical, but laboratory investigations, mainly PCR from aqueous or vitreous, it confirms the diagnosis. Serological tests are very helpful in the emerging new infections. A timely diagnosis and treatment can improve our visual outcome. Thank you so much for your patient hearing. Happy to answer the questions.
Thank you for your lecture. I have to stay in a specific topic. In other words, chikungunya presents sometimes conjunctivitis, and the same coronavirus. We have cases now of coronavirus with uveitis, and the characteristic sign is that we have depigmentation of the iris and circulation of pigments in aqueous humor. But in case of patients with coronavirus or chikungunya virus, my question is if we have some possibilities from the tear film investigation and scrapings of the cornea, we have some involvement with PCR. In other words, PCR can help us in the detection of cases of chikungunya virus or coronavirus by taking scraps from cornea or conjunctiva or even tears.
That's a very good question, actually, and it does help us. The tear film If not, we've not been doing it in other viruses, but we haven't done in chikungunya. But yes, we've been reading the cases where they've taken it for coronaviruses from the tear film, patient presenting with conjunctivitis, and they've been able to isolate the organism by PCR methods. But it's definitely a test which we look forward to, and it's such a non-invasive test rather than going for an aqueous sample or a vitreous sample.
Okay, thank you so much.